Hello, everyone. Welcome to DocTalks. I'm Dr. Manju George, the Scientific Director at Paltown Development Foundation, the nonprofit that supports Colontown. Today, we have the privilege of having the principal investigators of the ERASur trial with us to tell us about their trial. So I will turn this over to the panel. Dr. Miller, do you want to introduce yourself?
Yeah, thanks, Dr. George. So I'm Eric Miller. I'm one of the radiation oncologists at The Ohio State University.
Dr. Hitchcock.
Thank you, Dr. George. Thank you so much for having us here today. My name is Kathryn Hitchcock. I'm a radiation oncologist like Dr. Miller is, and I practice down here at the University of Florida. Go Gators.
Thank you very much for joining us. So we can get started. I think Dr. Romesser is in clinic, so he'll be joining anytime soon. So let's get started so we don't waste any time.
That sounds like a great plan. I'm hoping that we will get a lot of good questions at the end here. So we've intentionally written our talk to leave lots of time for good discussion in case folks are inclined toward that. So I'm going to start us off here. And the first thing I'm going to do, Eric, if you don't mind flipping to the next slide, is talk about what it is that we're treating here. This study, the ERASur study, is designed to treat oligo-metastatic colorectal cancer. Oligo-metastatic is a word that came about not too long ago to describe a situation where a patient does have metastases from their cancer, but there's only a few of them, and that's what that word oligo means. It's from the Greek word meaning just a few or a little. And the reason we needed a word for that, and the reason it was a new word, is that up until, not that long ago, 10 or 15 years ago, people really believed that if you had any metastasis anywhere in your body, that it was a signal that the cancer had spread to all of the parts of your body and that the cancer was therefore incurable. We know now that in many, many cases, that is not true, that there is a state in many cancers where, yes, the cancer has metastasized to a new place, but if we are really careful and a little bit aggressive in treating that one place or a few places, that we can still cure the cancer. And colon and rectal cancers are definitely the prime example of this. I would say that this is the disease that people always think of first when they think of curing folks with oligo-metastatic disease. And so some smart and brave people started really trying to cure the patients in that situation. That started out with resecting metastases in the lungs that were because they were easy to see even when our imaging was not so good. And you can see we've given you some references there showing where people were resecting metastases from sarcomas and also from colorectal cancer. The liver then was the next one after MRI became common and it was easy to find liver metastases. People started resecting those. And the reason the liver and the lung were the places we started is that you can live without quite a bit of those two organs. You've got a lot more capacity for lung than you really need. So if somebody needs to take some out, you're still going to do well afterwards and not have breathing problems. You might know that your liver is one of the few parts of our body that grows back completely. That's why we can donate part of our liver to someone else. And that part of the liver that's taken out regrows. So if we do a surgical resection on part of the liver, it's okay. You're going to be fine with the liver that's left over if it's done skillfully, and then that part of the liver will regrow. So that's how things got started. And ready for the next slide, Eric? So we have some really, really good technologies now that give us lots of different tools to try to address these oligometastases. As I explained, this started out with surgery, but there's places where you can't do surgery, or maybe the patient just doesn't want surgery to their body and all of the effects that that has. The other options that we have are SBRT, stereotactic body radiation therapy, which means very intense, very focused radiation therapy to kill metastases. There's also ablation that can be done in a lot of different ways. You see that in the middle panel on this slide. That involves putting a probe usually into the liver in order to kill a metastasis or multiple metastases there. And of course, we still can do surgical resection, and it's not uncommon for patients to need a combination of 2 or more of these techniques to address all of their sites of metastasis. I'm so happy to be alive in a time in which we've started to really accumulate lots of data that shows that those techniques that I just described to you really do help. And we've shown you some panels from couple of different studies here showing that if you do go after liver disease here in the leftmost graph, or lung-only disease, over here on the right, this is patients who had metastases in their liver that was unresectable, and so they were being treated with a combination of surgery for the resectable ones and that ablation technique for the ones that weren't resectable. And I think you can see here, if you look at these graphs, that there was a big difference in what happened to patients who got that intense local therapy and those who didn't. You don't have to be a statistician to see that those 2 lines are not on top of each other. And what that means is, when they went after these oligo-metastases and really treated them aggressively, it helped patients a lot. Even though, let's see, these studies were published in 2017, so you got to figure they started probably writing the studies in about 2007. And even, 5 or 6 years before that, it would have been very difficult to convince anyone to go after these metastases with surgery or anything else. So this was a big revolution in the way that we treat cancer. This was a very, very big deal. All right, I'm ready for the next slide. Eric, thank you. So the beautiful thing that's happened even more recently is that we've been able to show that SBRT, that intense radiotherapy, also does an excellent job of treating oligometastases. And it has been doing that for a long time. We've been using SBRT in this way for a long, long time now. Unfortunately, there's lots of radiophobia out there in the world, even among very educated people like physicians. And so it's been harder for people to accept using radiation treatment like it often is. But it's a great tool because it's the only one of those 3 techniques I showed you that doesn't involve poking any holes in your body. It doesn't involve any blood loss or risk of infection. And my patients, when I treat them with this technique for oligometastases, do very, very well. It's extremely uncommon for them to have really any side effect other than fatigue. So it's exciting, these graphs that you see here showing that when we use SBRT to treat oligometastases, we get those same excellent results that you saw on the previous slide for surgical resection and for ablation. And that's what the study that we're going to talk to you is all about. I'm going to hand it off to Eric. I think are you the middle slides here?
Yep. Thanks, Dr. Hitchcock. So as Dr. Hitchcock really skillfully described, we know the standard of care for patients who have a liver metastasis. If you remove that liver metastasis, either with surgery or with another ablative technique, we know that those patients do very well. And even a subset of those patients can be cured. So it can go a long period of time before any other type of cancer shows up anywhere else. So we know that there's a benefit to local therapy in this patient with a liver metastasis. Our question is, what if a patient has a little bit more metastatic disease? What if they have 2 lung metastases and a liver metastasis and a lymph node metastasis? What is the role of local therapy, such as radiation and ablation and surgery, for that type of patient? And really want to answer the question of why do we need a trial in this space? So right now, to date, there has not been a study looking at the use of multimodality. And when I say multimodality, I mean the use of radiation or ablation or surgery for metastatic directed therapy for colorectal cancer. It really has not been done to date in a systematic manner. And the reason why it's important is that, as Dr. Hitchcock described, imaging is improving. We have better techniques to find cancer and to detect cancer. We have better therapies to treat cancer. And so use of that type of therapy outside of studies is rapidly expanding. And rather than it being really evidence-based, there's really no science behind treating that type of distribution of disease. It's really provider biased rather than evidence-based. And we all know that you really want evidence to prescribe a treatment. And so the benefit of extending the treatment paradigm that we have for patients with liver-only disease, where we know there's a benefit, extending that paradigm to patients with more extensive disease is currently undefined, and you really have to balance it with any potential toxicity from the treatment. And so our trial, ERASur, is really hoping to fill this knowledge gap. And we've designed what we think is a practical multimodality approach that mirrors the current clinical dilemma that we're in. And so this is our study. It's a pragmatic randomized phase 3 trial evaluating total ablative therapy for patients with limited metastatic colorectal cancer, evaluating radiation, ablation, and surgery. And it's called the ERASur trial. And it's a joint trial between Alliance and NRG Oncology, two different cooperative groups, national cooperative groups focused on developing better cancer therapies. And we've really assembled a really great group of individuals with a lot of talent and expertise in different disciplines to help answer this question and conduct this trial. So the primary objective of ERASur is to evaluate and compare survival in patients with newly diagnosed oligo-metastatic colorectal cancer treated with total ablative therapy. And what we mean by total ablative therapy is treatment of all sites of disease using radiation with or without surgery and with or without ablative therapy with heat. Adding that to chemotherapy versus just chemotherapy alone. Number of secondary objectives for the trial as well, including looking at event-free survival, so progression of the cancer, looking at safety of the treatment, as well as time to local recurrence, meaning return of the cancer where the individual local therapy was delivered, so a local recurrence of the cancer. So this is the design of the study. So it's including patients with newly diagnosed limited metastatic colorectal cancer, and Dr. Romesser is going to talk about what we're defining as a site of disease, but it's 4 or fewer sites of disease on the initial baseline imaging that includes CT scans. The primary tumor, so the colon or rectal primary tumor, must be either already removed or able to be removed, BRAF wild type or microsatellite stable disease. Patients can't have liver-only disease because we know the paradigm for that already, that surgical resection or local therapy is beneficial in that patient population. So patients receive systemic therapy for 4 to 6 months. Those who progress on first-line chemotherapy are removed from the protocol because we know those patients should consider an alternative therapy. And then patients who do have residual disease, meaning that there is still disease visible on subsequent CT scans following induction systemic therapy, so that 4 to 6 month period of systemic therapy, these patients are then randomized to continue standard care systemic therapy or the addition of total ablative therapy. And that again is ablative radiation with or without surgery, and then with or without microwave ablation. And the primary endpoint of this study is overall survival. So I'm going to turn it over to Dr. Romesser to talk about the eligibility criteria.
Good afternoon, everyone. I hope everyone's having a nice day. Thank you for joining us. So thank you, Dr. Hitchcock and Dr. Miller. So when we're thinking about eligibility criteria for this study, we definitely want to limit it to metastatic colorectal cancer patients who are not known to have microsatellite unstable tumors, because those are patients who would likely benefit from a different type of therapy, largely immunotherapy. We don't want them to have a known BRAF mutations where they might benefit from BRAF inhibitors. No known peritoneal or omental metastases, just because that's not something that we can treat from a localized perspective. That takes a different type of treatment. And the primary tumor, the primary colon or rectal tumor, needs to either have been surgically resected or amendable to resection as part of this paradigm, meaning that we have to address not only metastatic disease, but any localized or primary disease as well. Patients can have up to 4 or fewer sites of metastatic disease, and we'll talk about what a site is, but liver-only disease is not permitted, largely because the studies that Dr. Hitchcock showed at the beginning have really reported on excellent outcomes where a subset of patients can have very prolonged progression-free and overall survival, or essentially cures as we see them. And so we don't think we need to reestablish the wheelhouse there. And then patients can have a maximum of 4 months of systemic therapy. So for registration, the patients can't have any progression on induction chemotherapy. They can't be eligible for hepatic arterial infusion pumps, which are gaining momentum and traction around the country. They must have measurable disease on imaging, And again, a minimum of 4 months of systemic, but maximum of 6 months. So really have to come in right in that sweet spot for eligibility. And if they had prior definitive or curative intent treatment, like such as stage 2 or stage 3 disease, they must be greater than 12 months out, or greater than 12 months out from completing that treatment. No pregnant patients, and everyone must be older than the age of 18 with a good performance status and labs as shown here. Sorry, my eyes watering. So what's a metastatic site? So it's interesting. It needs to be radiographically evident. Biopsy or pathological confirmation is not required, but the patient does need to have a diagnosis of metastatic colorectal cancer. The lesions must be amenable to any combination of surgery, microwave ablation, which is an interventional radiology technique, and or stereotactic body radiotherapy, which is SBRT, or stereotactic ablative radiotherapy, which is SABR. They mean essentially the same thing. So what's a single site? Well, each side of the liver, we have a right and left side of our liver. So that's the right side would be one site, the left side would be another site. Each lobe of the lungs is a site. So in the right lung, we have 3 lobes. In the left lung, we have 2 lobes. And different organs, like each adrenal gland. We have 2 adrenal glands on either side of our body, and those would be considered, each of them, a single site. Lymph nodes are a little bit harder to define because lymph nodes obviously can be next to each other or spread out. But if the lymph nodes are amenable to a single surgical resection or can be treated in a single SABR radiation field, that would compromise a single site. And bone metastases amenable to treatment in a single SABR field or a single site. And we left it intentionally not overly restrictive or confining to allow flexibility of the sites of the centers or the doctors to kind of have flexibility in kind of determining, who's a good patient and to what level can we enroll them at. So the study interventions, the control arm, it is a randomized study, so patients will be randomized to either control or the experimental arm. The control arm is going to be continuing the standard of care chemotherapy. We allow maintenance chemotherapy as well as local metastatic directed therapy for patients who have, pain, discomfort, or need palliation. But for lesions that are not causing any symptoms, we don't allow local therapy, and that's really kind of the standard. On the experimental arm, we give up to 3 months to essentially complete what we call total ablative radiotherapy or total ablative therapy, which is, again, surgical resection, microwave ablation, or SABR to all sites of disease. And thereafter, we ask the physicians to reconsider starting chemotherapy as is. Again, chemotherapy breaks on both arms are permitted at the discretion of the primary team, and those often do occur in the real world. And so it's meant to be somewhat pragmatic in terms of mirroring what's happening in the real world setting, but really looking at the addition of TAT, or the total ablative therapy, in this cohort. For a core live study perspective, we'll be asking patients to agree to allow us to bank their blood for future ctDNA studies. And I want to point out, one thing that Dr. Hitchcock, Dr. Miller, and I were really, proud about and enthusiastic about. We approached Dr. George, who you all know, early on and said, we're designing this trial, but it's important for us to hear from patients. It's important for us to get the patient input. We wanted to know, was this something that they're interested in? Was this enthusiasm? And also, we asked very pointed questions about what would they prefer and in what order and to what degree they thought, we should let patients enroll, and what sort of different types of treatments they would agree to. And so the patient perspective and the patient input for this trial was absolutely critical, and it was critical from an early development time point. So I want to thank Dr. George, the entire Colontown family, and Paltown on behalf of all of us in terms of helping us with the trial design. And I think that's really something that I know that we're all very proud of. Separately, I also want to point out that y'all input helped us get this trial through and approved. 90% of you responded and said you would consider enrolling on this trial. 70% of you were enthusiastic for a potential treatment break in terms of considering maybe omitting maintenance chemotherapy in the setting of using maybe CT guided DNA analyses. Unfortunately, the National Cancer Institute and the GI Steering Committee felt like that was pushing the envelope a little bit too much, and they kind of dialed it back. But that's something we're going to look at in the correlate studies and something we're going to consider for future studies down the road. And having something like this, where we're showing 90% enthusiasm, 70% enthusiasm, this is unparalleled. And I just want to really highlight that this made a really big deal, and it was incredibly impactful when we brought this to the National Cancer Institute in terms of showing feasibility, enthusiasm, and overall need for the trial. So thank you very much. So with that, I want to invite Dr. Hitchcock and Dr. Miller to kind of chime in here as well, and just really wanted to say we want to answer your questions. We want to highlight the trial, but we wanted to come here to thank you, most importantly, for your input with the trial design, and we hope that you'll continue to support us and guide us as we lead this trial over the next couple of years. Dr. Miller, Dr. Hitchcock?
I think we've started to get some questions here in the chat. So if it's all right with you, Dr. George, I'll start working our way down the list here. One question: when do you expect the sites to start recruiting? The study is officially open, and there are sites all over the country right now that are working on getting it open. You would be appalled if you saw how much paperwork it takes just to make it possible to treat somebody on a study like this. So I think everybody everywhere right now is in the process of getting this through the institutional review board where they are, meaning the people who take a look at studies to make sure that they're going to be done ethically and are going to respect the rights of the patients who might be treated on this study. And the minute that's approved, we are ready for action. We're so enthusiastic to start getting patients onto treatment on this trial.
Dr. Hitchcock, I was kind of wondering that since the video will be posted and this trial is now in the featured trial sections on Colontown University, it would be kind of nice to know, or if someone can give us a list of what places they're open, we would be happy to put it up on the website. So that I think this is a question that we often get from patients, like they want to know where it's open so they can talk about it. So that'd be nice to know, like as you get information on, where all it is open.
That sounds like a great idea. And I think probably the smart thing would be, I think there will be the Alliance Cancer Research Group is sort of the lead on this. Probably we can find a link to their page that shows which sites are open. We'd be happy to pass that over so we can drop that into the site.
Yes, that'd be great.
Yeah, and also
changes by the day. So having the site, I think, would be critical. Sorry, Dr. Miller.
Oh, no, thank you. So also, I think on the Colontown website where it's a featured trial, there is a link to the clinicaltrials.gov site, and that actually will contain, once sites are open, it'll contain where all it is going to be open or where it's open right now. It takes a little bit, a couple months for it to actually get open, so we're getting closer.
Okay. I think there's a question about the sites.
Yeah, there was a question about, does 4 or fewer sites mean you could have more than 4 spots in METs as long as they were confined to less than 4 sites? That's exactly right. That's how you interpret it. So you can have, for example, in the right upper lobe of the lung, you can have 2 or 3 individual METs or lesions there, and that would be considered 1 site. So that is 100% correct.
Would a patient that had a recurrence after curative intent liver resection be eligible?
Yes, they would. There's a time limit. A certain amount of time has to pass between that curative attempt and being treated here, but it would definitely be worth looking into this study in that situation.
Mhm. I think the next question is about somebody from New Zealand. Would you consider patients located outside US?
Absolutely, yes. In the United States, it always just comes down to how the hospital is going to get paid. So as long as that end of things could be worked out, I don't see any reason that we couldn't treat somebody from anywhere. We would love to take care of that patient.
Yeah, so the next question is, would a patient have to have primary resected? I'm not clear on amenable to resection. What does that mean?
So great question. So it either has to be resected before they get into the trial, or in the early period of the trial, it has to be resected. So amenable to resection means it's possible to be resected and the patient agrees to have their primary tumor resected, because the question that we're testing is in people who don't have their primary tumor still sitting there as a source of potential new metastases.
Mm-hmm. I was kind of wondering, could you go back a couple of slides where you had the control arm and the experimental arm?
Yeah, which one do you want to look at?
I think there was one where you had on the left side, you had the control arm. Yeah, that,
sorry,
the study interventions. Yeah. So I was kind of wondering, can we think of a hypothetical patient and then kind of go through each step, how that would be, so that people are really clear about, how this is happening. So let's say I'm a stage 4 patient and I have, a primary tumor in my colon, and then 1 or 2 mets in my liver, a couple of lymph nodes in the abdomen, and then 1 or 2 spots in the lung. So do I register now, or could you walk me through that?
Yeah, I can try to tackle that one. So we actually designed it so that you can register really at any time during that initial 6-month period. So you can register before you start chemotherapy, or you can register, and that would be called pre-registration, or you can register after that 4-month chemotherapy period and register at that point. So you can kind of register all throughout induction chemotherapy. But essentially, you would finish at least 4 months of chemotherapy. You would register to the trial. At that point, you would then, make sure that you would meet all the eligibility criteria, the lab values, make sure everything else is in order. You would have restaging imaging. And the one thing that we had talked about, kind of maybe glossed over a little bit, is to make sure that there's still something to treat. So if everything disappears on that restaging imaging, that's great. But that would mean that you may not need local therapy, and we want to make sure that we know what we're treating. And so there needs to be something that we can actually see on the imaging to treat. And so at that point, then you would be randomized for patients who still have something visible to treat. You'd be randomized to either continue chemotherapy or local ablative therapy, or TAT plus chemotherapy. There is some time built in there where you could get additional chemotherapy if necessary. We allow up to 90 days to get the total ablative therapy done. And so you work with your primary team. If you're randomized to the TAT arm, you work with your primary team to figure out the best combination of therapy to treat all areas of disease. If you randomize to the chemotherapy alone arm, then you would continue with chemotherapy. And then after you finish that treatment, you would then follow up with routine imaging scans and blood tests as you would off of this study. Did I miss anything, Dr. Hitchcock or Dr. Romesser? Sorry.
No, I thought that was a great explanation.
Okay, so can I ask some questions about it? So when people are getting chemo, they can get anything. They can get FOLFOX plus the biologic. If some patients wanted FOLFOXity, they would still be able to get that too, right? Or yeah, okay.
Yes,
and then
we fought really hard for that. There were folks, our advisors along the way, that wanted us to specify, but we wanted people to have lots and lots of options, especially since everybody's situation is different.
Okay, that sounds good. And then so you get like 4 months of chemo. So let's think of my case. So I got 4 months of chemo, and then I had imaging, and 1 met in my liver is gone. The lymph nodes have shrunk down. I can't find anything on my lung. So I have now mets in the liver and the lymph nodes. So which means I can still continue with the local ablative therapy, right?
Correct. That's exactly
Yeah.
right.
Okay, and then I have 90 days, during which time I can get radiation to the lymph nodes, maybe have something done to the liver, and then I have that much time off chemo then? Is that what is meant? Like in that 90-day period, I can get all the local treatments done?
Exactly, because most of the time, if you're doing these more concentrated therapies, you don't keep chemo going. You want to make sure the body has a chance to recuperate from what it's been through. So you get a chemo break during that time. Exactly right.
Okay, and then after that, after the 90 days, you have one imaging, is it? Okay, okay, and then you can continue with the, either maintenance. So let's say after the imaging, there is nothing seen on scans, and you also have blood draw for ctDNA, and then you can, so I can talk to my care team, and if all the lesions are gone, I can go back to maintenance, just get CAPE, BEV, and continue. Or if I wanted to take a treatment break, would it be possible to take a treatment break too?
Absolutely, yes.
Okay, okay, okay. And then you're going to watch me to see when those lesions come back, or if I have additional lesions. That's what you're trying to look at, right?
Correct, exactly
okay.
right.
Okay, okay. Thank you very much. This was this was very clear. Let's see if there are other questions. Okay. Paula has a question. If there is a large tumor considered to be one tumor, but in both the right and left lobe of the liver, does this qualify as two sites?
Good question. Actually, we didn't think of that scenario, but I would probably count it as two sites.
I think the way we have it written, it would
Yeah.
probably count as two.
Yeah, it would be a judgment call, but probably two. To go back, just one thing to add to the, I think that was a great explanation, Dr. George, of and a great thought experiment of going through the trial. But so you would have the 90 days to finish TAT, and then the first imaging time point is really 1 month after finishing TAT. So you finish TAT, let everything kind of calm down, and then 30 days after that is the first imaging time point, and then it's every 3 months that you would kind of do normally. But yeah, everything else was exactly correct.
So Betsy has a question. Could I get the slides to post in Liver Lovers Lane, Lungston, and Legosland? So these are Colontown groups for different Mets. So yeah.
Absolutely, yes. Yeah.
Thank you so much. This was very helpful, especially walking us through a scenario that was really helpful. Let's see if people have other questions. We have plenty of time. Yeah, brain mets, are they eligible?
Unfortunately, no. We went back and forth about this early on, and they would not let us include folks with brain metastases.
Okay. Okay, and then I had this question about ctDNA. So are you planning a certain time points? Like, how's that being planned?
We've built in specific time points where we're asking all the sites to draw blood for ctDNA analyses. So they'll draw the blood, spin it down, and send it to a central repository, which then we can actually go through and do the analysis after the trial is complete. Okay. So they are standardized. There's 4 or 5 of them throughout the trial that are pretty well standardized. So that's something we're hopeful that patients and sites will enthusiastically participate in.
Okay, so the only thing, like what you explained with the GISE not allowing the ctDNA testing. So if it's going to a central facility, that means that people won't be able to, you're probably not analyzing it during the trial, is it? Correct.
We're not analyzing it during the trial now. That's not to say that, there are some centers that are routinely using ctDNA and they may still want to continue their standard practice. Others aren't doing that in the metastatic setting. So we're not here to, opine on that or to prevent anyone from using it. But from a, scientific perspective, we won't be able to use an external ctDNA test that a site is using. But if we have a little bit of that blood bank, we can go back and with 1 or 2 vendors go back and do the analysis for the whole cohort. And we're certainly very enthusiastic that it may identify or help us identify patients who would maximally benefit from these types of interventions in the future.
Okay. So just not to put you on the spot, but just to ask, so when you said that if there was a site that was already using ctDNA testing for these kind of patients, then those patients would get the result, but the blood would be banked, and that banked blood is what you will do for your analysis for the trial endpoints. Is that what you meant?
Yeah, so the banked blood is just banked. It's not analyzed in any patients up front.
Okay. Mm-hmm.
But if a doctor at site Y, for example, routinely sends ctDNA on their patients, his or her patients, he or she can still, on their own accord, draw an additional tube of blood and send it for real-time ctDNA analysis.
Okay.
That's just not part of the trial. It won't be included in the trial, and that's not data that we collect on the trial.
Okay. So, sorry to belabor this, but what it means is that if the patient is in a center where they routinely use ctDNA, then they would be able to get the results of the ctDNA testing too. But if it's not, then they won't have the data because that data is not analyzed till the end of the trial, right? Okay. Yeah, it's good to know because we didn't want patients to be confused, that they should.
I'll put it maybe a little bit more clearly. There's no ctDNA. Patients will not get any ctDNA information or testing done in real time on this trial. Any ctDNA testing that they want done on this trial is outside of the trial, and their provider will have to do that separate.
Okay.
But with that said, they can still make decisions based on that. We've intentionally left it so whatever information you have with your care team, whatever decisions you are going to make normally, we're not stopping you from making that decision on this trial. We tried to make it as unrestricted as we could so that we weren't taking any options off the table for anybody.
Okay.
Absolutely.
Okay. That's
absolutely.
Sorry. Yeah, I think that's a great point because I think that's where I was trying to get to. The design is in such a way that it allows the maximum flexibility, and for every patient wherever they're located, based on what their care team is doing, they can actually use the tools that are available in the trial, but then they have the care that is almost tailored to how they're getting it anyways, right? Yeah, okay. Paula has a question. How does insurance handle this trial? Can the patient remain where they live, or would they need to be at a specific center long-term?
The beautiful thing about this is you have to be treated at a site that has the study open. So you can't enroll in the study at one hospital and then go get your ablative treatment at another. However, you can get your chemotherapy someplace else. So we were hoping that would, for patients who don't have an enrolling a hospital near them, they could come and get enrolled and get their local therapy if they were assigned to that arm, and then go back home and get their chemotherapy and not be stuck anywhere for months and months getting chemotherapy. But any center that has the trial open can do the local therapies. There's not one or two sites. We're hoping to have, in fact, quite a few sites. So hopefully there'll be one close to everybody who wants it.
Okay. Thank you very much. That's a great point. Great question, Paula. So basically, I will just summarize what you said. So chemo, if I'm a patient enrolling in the trial, I can get the chemo at my local, wherever I get my treatment, but I have to enroll at a place where I will get the local therapies, right? The local ablative therapies, that has to be done at a center that's close by. And from what you've explained, that's only for the short duration of time, whether I'll have that local surgery or the ablation or the radiation, that I'll go to that center, have it done, and then I can come back and continue all the rest of my treatments here. What about imaging? Where will I have to do the imaging?
Imaging can also be done close to home.
Okay, great. This is really very, very patient-friendly and patient-centric design. Yeah,
that's
thank you so much.
Exactly what we were going for. Thank you. You just made our day by saying it. And again, that's because you all weighed in and made your opinions known. Without your input, we could never have made it that way. We're so grateful for the time that people took to educate us on that.
So what else can we do to spread the word about the trial? Like, how can we help?
I think we just want patients to know about it, that it's an option, that it's maximally flexible, it's pragmatic. We're not here to put up barriers, we're here to break them down. And we hope that, you know, even if the trial is not open where your primary site is, you'll talk to your doctor about it, and we can link you up with some, locations where it's open. And we hope to see that, you know, it's not only at big kind of cancer centers, but that it's kind of spread out around the country, and patients kind of come in for this trial to seek out TAT, or at least to help assess the question.
Okay. Thank you very much. As I was talking, so we have on Colontown University, we have this diagnostic and surveillance test learning center. It's a different topics, but where I was going with this is that, so we had, like, for example, when patients started using Signatera, not everyone was ordering the ctDNA test. But then what we did was that we asked patients to let us know where all they were getting the test. So then we actually put up a list of centers where they were getting the test. So any new patient, when they wanted the test, they could go and check to see whether there was a center close by. So I think that one of the things that we can do to facilitate, people knowing about it is, as soon as you know that there is a site open, or, certain techniques can be done in a particular place, if we can provide a list, where what is available, then that would be very helpful, because then people could go and click on it and find out, how far it is for them. And I think that might facilitate, more people knowing about it and enrolling. So that should be something that we could do on Colontown University.
That sounds great.
And I'll add one more thing. Some big centers have, like I know in New York, and I'm not trying to plug my own center, but I know in New York, we have the American Cancer Society has something called the Hope Lodge, which is a free lodging. So it's not just unique to my center, right? It's available to anyone with cancer who comes to New York City for treatment. And so there are resources if there's not something close to home where we could find other additional options for patients. And I think there's many Hope Lodge equivalents around the country at many great sites that we could try to put together to increase options for patients as well.
I think that's a great idea. Any other questions, comments? Yeah, so we've worked with, Dr. Miller and Dr. Romesser and Dr. Hitchcock. So we have this trial design and more details about this trial up on feature trials on Colontown University. So if, you've heard whatever you heard them speak, and then you wanted to, look at those, the details, and, when you have time, you can go over there and it's there. And Betsy will post, I think one of you will send me the slides, right? Then I can send it to Betsy, and Betsy will post the slides in Langston and in all the relevant metastatic groups. Yeah, that would be great. So there are multiple ways that people can know about it. And then the other thing that we've been doing in Colontown is that when we have newly diagnosed patients join, when we actually have onboarding, so we ask them, to tell us about where they are and what's going on. So when we come to know that they might be eligible for certain trials, then we tell them that there are these trials, because many a times, when patients join, they don't know anything, and it's sometimes they won't come to know about it. And trials are not, in general, people think that trials are something that, when you have failed all lines of therapy, that's when they should do it. So we try to tell people about first line trials like this. So that's another place that we would be talking about it. Yeah.
That is perfect. I'm so grateful that this whole system exists. You guys have put so much work into it, and the good that comes out of that just can't even be measured.
Yeah, thank you.
Dr. Miller, do you want to comment on the insurance and the insurance review that you all did through Alliance as part of activating the trial?
Yeah, so that's a great question. So they do an insurance analysis to make sure that aspects of the trial will be covered, and we went through that analysis and everything checked out. Now, of course, before any treatment, of course, they would do a prior authorization to make sure that all treatment would be covered, but there really isn't anything on this trial that is really experimental. All the local therapies are established therapies that would be covered by insurance.
Yeah,
that's a great question.
Yeah, one of the things I think we can also do is as people start, 6 months or a year from now, and when we find like, we also have in Colontown, Betsy is one of the cabinet members. So we have a group of patients and caregivers who run the day-to-day activities in Colontown. So we have something called the Alana Project, which is basically a place where we keep track of who all are in what all trials. And, they'll post updates. So if they have a clean scan, they'll post. If they have a progression, they will post. So this way, when a new person who wants to find out about trials, they can go and look in the Alana Project and find out if other people have been on the same trial and what their experiences are. So once we, a couple of, 1 year or something after the trial is open, we're hoping that we will get to hear from patients, right? How this is going, what, if there are concerns. So I'm hoping that we can bring that back to you. And, if there is something that is in the way, maybe, I don't know, maybe you can do an amendment, or, you can at least find out if there are ways to help, for people to get over that block, whatever that is, right?
Yes, if there are barriers, we really want to know about them as soon as possible, because you're right, trials, it's not like you write a trial and it goes through as written from the beginning. There's always amendments when we figure out that something didn't work quite the way we thought it was going to. So please, that would be wonderful if folks would communicate with us in that way.
Yeah, okay. We can certainly think of collecting information, because I think overall, so I would like the three of you to tell us, how, in your mind, like when we have the results, what are you hoping for the field from this trial? Like how is this going to be practice changing? I mean, if you could comment.
Yeah, I guess I can start. I think for us, the big thing is just clarifying the role of local therapy in patients who we wouldn't necessarily think about local therapy for. So if it's shown to be beneficial, then we should be offering this therapy to more patients. So one of the impetuses for this trial was that for the vast majority of metastatic colorectal cancer patients, there aren't really new drugs right now. Systemic therapy is sort of at an impasse. And so if we can come up with a different method, if we can offer local therapy and improve survival, we need to figure out the patient population that's going to benefit. And on the converse of that, if we're doing things that aren't helpful, that are just adding toxicity and increasing the cost to patients, then we probably shouldn't be doing those things. But I'll turn it over to Dr. Hitchcock and Dr. Romesser.
And I would say part of that we've kind of touched on today, in that I know a lot of patients in the process of dealing with this specific disease situation don't ever get a treatment break. And that was kind of where the idea came from originally, not just the chance for curative potential, but if that doesn't happen, are we able to at least give patients a long, meaningful period of time where they're not constantly in the hospital and dealing with doctors? So at the very least, we're hoping we can achieve that.
Dr. Romesser, do you have something to add?
I think they summed it up really well. I mean, I think whether it's unique in that whether it's positive or negative, I think it's going to impact how care is administered. Obviously, we spend a lot of time working on this, and we're very passionate. We have every reason to believe this is going to be positive. But I think we can learn from both ways. And so we're just really kind of humbled by the opportunity to run this trial and to offer this to patients.
Okay, thank you. I think that's one question. It is this only for first-line patients, or is this also for patients who have had other treatment?
It's predominantly first line, unless they had other treatment for stage 1, 2, or 3 colorectal cancer.
So I was thinking that, like, I really liked what all three of you said. So from a patient perspective, what you're really saying is that right now, when somebody's stage 4, we hear this chemo for life, right? That's what we hear for a lot of patients. So basically what you're trying to do is you're trying to break that big group of stage 4 patients into smaller subsets to see if there is a group that you can treat, many of their mets locally, so that they don't have to be on chemo for life. They have these treatment breaks, and hopefully, the best case scenario would be they are cured by it. The worst case scenario is that they get a treatment break and their disease comes back after a long period of time. So then, that is essentially a long chemo break for them, and that adds to their overall survival. Have I kind of summarized it?
That's it exactly.
Okay, thank you. Any parting comments from the listeners?
This is Betsy, and I am the community leader for the metastatic groups, and I'm really excited about this trial, and for all the reasons that you said. And I'm just, I don't know, this is exciting, and I think patients are going to be very excited about the trial. And I'm happy to share the information, and especially with the initial onboarding, we do get a good sense of some of these patients and the extent of disease, and try to talk to them immediately, because it's such a good opportunity when they come to us new, and you're able to talk to them about treatment options. And so I think, this is great. I mean, I keep saying exciting, but I am excited because I've been doing this a long time, and I think that there is a real need for this. It needs to happen, like you said. So I'm appreciative of all you're doing.
Yeah. Thank you so much, Betsy.
It's good to hear you're as excited as we are. We are on the edges of our seats for sure.
I think that's a great point about it being, first line and not necessarily thinking about trials when you're first diagnosed. So I think if we can let patients know about it early and potentially give them an opportunity, I think that is exactly what we're hoping as well. So thank you.
Yeah. Okay. So I think then we can thank everyone, and thanks to everyone for joining, and thank you, Doctors Hitchcock, Miller, and Romesser. And I hope that with all of this, we will be able to tell patients about, we'll hope to be able to take this information to the most number of patients, and kind of help with enrollment too. I hope that's together we can, get the trial enrolled, and get everything going quickly.
Thank you.
Yeah, thank you so much. We'll send the slides.
Okay. Thank you very much. Have a great day.
Thank you. You too.
Bye.
Bye.